Good afternoon and welcome to another segment in our ANAwareness Week 2021 webinar series. We're here this afternoon with Dr. Elizabeth Bradley, an ophthalmologist at Mayo Clinic in Rochester. And today we're going to talk about managing the eye in facial nerve palsy, an incredibly important topic for post-treatment AN patients. Dr. Bradley, I'll have you tell us a little more about your work with AN patients in just a moment. First, I'd like to mention a few things about how our presentation is going to work this afternoon. If you've been here before, you've heard this, but if you're new and this is your first presentation, I'll just go through it quickly. All of our attendees are muted. So if you have questions, there's a question box in the webinar that you can click on and you can type your questions in there. If you're on Facebook, you can just type them into the comment section. We're monitoring that. And then there's also should be captions at the bottom of your screen. If you do not see those on the webinar, there's a captions button in your toolbar you can click. And on Facebook, you may have to activate them in your settings. We are recording this presentation and we'll house it on the ANAwareness Week landing page in the presentation section. We'll also keep it on our Facebook page and add it to the ANA website in the video library. And there's lots of ways to get involved in ANAwareness Week this week. You can visit our website at www.anausa.org. Click the slider on the homepage and that will take you to our landing page with everything you need to know about ANAwareness Week. All right, Dr. Bradley, thank you so much for being here today. Thanks for joining us. If you want to go ahead, that would be great.
All right, thanks, Melissa. So as Melissa said, I'm Elizabeth Bradley. I'm an ophthalmologist and specifically an oculoplastic surgeon. So I do plastic and reconstructive surgery of the periocular region, and I'm at Mayo Clinic where I collaborate with Dr. Mike Link, Dr. Colin Driscoll, and our other skull-based surgeons. And then I have a special interest in the eye manifestations of facial nerve palsy, not just due to acoustic neuroma and other intracranial processes, but also from the more common Bell's palsy. So we have a multidisciplinary facial nerve clinic at Mayo where we've taken care of a lot of these patients. So this talk is really geared towards both patients and clinicians, but understanding that we mostly have patients in our audience, I'll gear it in that respect. And so there are some slides that I may just skip over if they're a little bit too medically oriented. So I don't have any financial relationships. I won't be talking about off-label usage, and I will be presenting some full-face photographs of patients, and patients have given us their authorization to present those in a public setting. So we'll be talking about the periocular, so around the eye, as well as the ocular or eye manifestations of facial nerve palsy. You talk about both non-surgical and surgical treatment options for the eye problems due to facial nerve palsy, and then I'll talk a little bit about some of the surgical techniques in particular for the upper and lower eyelid. So first I'll start with a case that of a 62-year-old woman who was referred to me when I was on our hospital service. She had had a cerebral pontine angle tumor resected 5 days previously, intraoperatively had had her cranial nerves monitored. Cranial nerve 5 is the one that provides feeling to the eye and the face, and then of course cranial nerve 7 being the facial nerve. And those were intact throughout the procedure, but she awoke from surgery and had weakness of the left side of her face. But because those nerves were structurally and by electrical monitoring were intact, during surgery, we really expected her surgeons expected her to fully recover function, so we needed to nurse her along in the acute postoperative period. So on postoperative day number 1, some artificial tears had been started, and then some ointment had been added on postoperative day 3. She was feeling that the eye felt a little bit irritated, and then again, we were seeing her on postoperative day 5. And so what we can see in the picture is a pretty typical picture of a peripheral facial nerve weakness. So it affects one side of the face from the brow down to the lower face. She has a wide, what we call palpebral fissure. And so her eyelid opening is much wider on the left side than on the right side. We can see that the eye has kind of a glassy look to it. That's because of what we call a high tear lake. The tears aren't draining appropriately. The conjunctiva, which is the white part of the eye, is red or pink. It's what we call conjunctival injection. And then when we tested the cornea by touching a little piece of cotton to it, she didn't blink as much, or she didn't perceive it as much on that left side. as she did on the right. So it was not a completely numb cornea, but definitely does not feel as well on the left than the right. And then when we take a close-up photo under our slit lamp, high magnifying equipment, we can see that there's a green patch there, and that's where the surface of the eye just isn't healthy. It's already starting to break down. And so to summarize what our thinking was at that time, so here's a patient, she already has basically a scratch on her cornea, what we call an epithelial defect. She doesn't have normal feeling of the eye. Bell's phenomenon is whether the eye rolls up with the tinted eyelid closure. And on that previous slide, if we go back to this slide, we can see that when she tries to close, not only do the eyelids not come down, but that eye just stays looking straight ahead. So that's what we call that poor Bell's phenomenon. Really, the protective mechanism that many, but not all people have, is for that eye to roll up underneath the eyelid. So lacking that puts her at increased risk for having that cornea exposed. And then she was already on maximum lubrication. So those were all the bad things. But on the other hand, we did expect recovery of the facial nerve. And so for that reason, we decided that really of the different options, which I'll talk about, for this particular patient, we thought that a temporary tarsorrhaphy was our best option. Just something to just temporarily close those eyelids, put the eye at a little bit of rest for 4 to 6 weeks while we wait for some recovery to happen. So what are some of the things that we're thinking about as we assess a patient for their risk of developing a cornea problem from a facial nerve palsy? Is how severe the facial nerve palsy is, whether it's a complete or partial facial nerve palsy, how long it has been going on for, and how long it's expected to last for, whether the feeling on the cornea is intact. That's so critical. So if that cranial nerve 5 that provides feeling to the cornea is affected, then patients can't feel when they get into problems, and they can't regenerate their cornea as well. And then that Bell's phenomenon that we talked about, and then also what the patient's access to care is. So if it's somebody who lives locally and can come in and see us on a regular basis so that we can see how they're doing before they get into trouble, then we're more comfortable with being less aggressive. But on the other hand, if it's a patient who lives a long ways away or in a very dry climate, or patients who have problems with transportation, then we're going to usually recommend that we're more aggressive so that we don't get into trouble without realizing it. So what are some of the options for how to take care of the eye? And we'll walk through these. First and foremost, increasing lubrication. And then we'll also talk about contact lens therapy, tarsorrhaphy, which means joining the upper and lower lids together, placing an eyelid weight, and then the lower eyelid. So for lubrication, the questions that commonly come up when I talk to patients are what brand of tears, how strong or viscous they should be, and whether they should use preservative-free tears. So in terms of the brand of tears, I tell patients it really is like choosing a toothpaste. There are so many different lines of different brands of drops. Some of the favorites of my patients have been Genteel. They make a line that goes from mild, moderate, severe, and even a gel. The Refresh line, same thing, mild, moderate, severe, and then that gets Celluvisc is also the Refresh line. Sustain also. So it's really very much individual preference. I tell patients, plan on just going and spending probably $100 in the dry eye section of Target or Walgreens when you first go, and stock up on a bunch of different things, and just by trial and error, figure out what you like the best. So in terms of what strength or viscosity, how thick it is, really the thickest that doesn't blur your vision. So the thicker the drop, the longer it will last, but the more it'll blur your vision. The thinner the drop, the more often you'll have to put it in. So it's just always that trade-off. And then what about preservative-free drops? So those are the drops that are, for example, like the Celluvisc or the Refresh that come in the small little individual use vials that are not recappable. Those are fine. They're more expensive and they're not as convenient. The fact of the matter is most patients do just fine with preserved products. Most patients don't have a sensitivity to the preservative. So as an initial step, I tell patients to go ahead and start out with the more convenient and less expensive standard drops that have a cap that are not preservative free. And then only if you're consistently developing redness, itching, irritation from the preservative, would you need to switch to the preservative-free drops. And then a word about contact lens therapy. So we have two types of contact lenses. There is the most common kind that we use, which is we sometimes refer to this as a bandage contact lens. This is a soft contact lens that's identical in every way to standard contact lenses that people wear for sight, where they have a disposable lens that they may replenish every 2 to 4 weeks. The difference being that these don't have to have a prescription in them. So it's the same maker. There are a couple different companies. We often use the AccuView Oasis lens. And these are great for patients who have already worn contact lenses and are facile with manipulating the lens, can put it in and take it out. But we also definitely have used them in our elderly patients who've never worn contact lenses. And some of the caveats there are that they can safely be left in for up to a week, or even we can push it out to 10 days of full-time use, meaning sleeping in the lens. But we always add an antibiotic eye drop to that because that is a riskier practice in terms of the risk of getting an ulcer on the cornea. So we will add an antibiotic if a patient is sleeping in the lens, using it full-time, or even if they're taking the lens out on a daily basis, but if they already have a scratch on the cornea, then we will also add an antibiotic eye drop, and that's a prescription eye drop, and that's just to prevent the ulcer forming on the cornea. So that's the bandage contact lens. And then a more long-term option in patients who especially have facial nerve palsy in conjunction with that cranial nerve 5 or feeling problem with the cornea is what's called a Scleral contact lens. This is a custom-made contact lens. They run anywhere from $600 to $2,000, typically are covered by health insurance, including Medicare. We have an optometrist in our facial nerve clinic who manages all of our scleral lens therapy. But so the difference is a scleral lens. It's still technically a soft lens, but it's a little bit more rigid than a standard soft lens. It sits on the white part of the eye. It doesn't actually touch the cornea. You can see here this blue space behind the contact lens. That's basically a reservoir that gets filled up with an artificial tear solution so that tear solution is constantly bathing the cornea. And so we've had patients really with severe eyelid injuries, burns to their eyelids where they have very poor functioning eyelids, and the scleral lens can really essentially replace or take over a good amount of the function of an eyelid. And we've been able to heal some very damaged corneas using scleral contact lenses.
Dr. Bradley, can I ask you to move just a little closer to your microphone? Your audio kind of fades in and out sometimes.
Sure. Yeah. Is that better?
Yeah, that's a little bit better. Let's try that.
All right. I think the other thing is let me look at my audio options here. Is that any better?
That seems better. Yeah. Mm-hmm.
Okay.
It just kind of is in and out, but that seems better.
Okay. That's a different microphone. Let's go with that. Just feel free to interrupt me, Melissa. If you need
Oh, wait. No, that's quiet.
Oh, not so good? Okay.
No.
There, is that better?
Yes, that's better.
Okay. Okay, so let's talk about options for tarsorrhaphy, which is joining the upper and lower eyelids. So we can do that on a temporary basis or a permanent basis. With temporary, we can use Botox to the upper eyelid, that paralyzes the upper eyelid, but it lasts for about 3 months. We can use basically super glue, cyanoacrylate gel, to the eyelid margin. Or my most common approach is to numb up the upper and lower eyelids and use a suture to join them together. And I will routinely leave a temporary tarsorrhaphy in for up to 3 months. Or sorry, let me say I'll routinely leave it in for 6 months. I can leave it, I've gotten as long as 6 months. Sorry, I will routinely leave it in for 6 weeks. I have gotten up to 3 months out of a temporary tarsorrhaphy, and I'll show what one of those looks like. And then with a permanent tarsorrhaphy, that's where we're actually cutting the layers of the eyelid and joining the upper and lower lid together. We call it permanent. It can be divided, but sometimes the eyelid doesn't return entirely to normal. Sometimes the eyelashes can get disrupted with that approach. Melissa, is my audio okay?
Yes, that's better. Mm-hmm.
And so this just shows what a temporary tarsorrhaphy looks like. Again, this is that patient we looked at the very beginning. We've numbed up the upper and lower eyelids and then use a permanent suture and then what we call a bolster, and that just prevents the suture from pulling through the tissues. And our goal is to close the eyelid by about 1/3 to half so that we can still see to examine the cornea and the patient can see looking straight ahead, but will have impaired vision and gaze out to the side. And then just another picture of what a temporary tarsorrhaphy can look like. All right, so eyelid weights, there are two types of weights, temporary and then permanent that we surgically put in. And the permanent is much more common. So let me just talk briefly about the temporary weights. So this is made by a company called MedDev, and it goes by the brand name of Blink Ease weights. They come in these 5 different flesh-colored tones. The patient applies them daily. The weight comes with a series of double-sided adhesive strips. I think they send you 30 or 90-day supply of the strips, and then those can be reordered. The physician writes a prescription and the patient orders online. They retail for usually substantially less than $200. I think the most recent patient I had told me they paid about $120 for their Blink Ease weight. And for patients who are very motivated and who have a temporary facial nerve palsy, these can be a nice option. Now, not everybody has the right configuration. Not everybody, if people have a lot of skin that hangs down, sometimes they have a hard time getting the weight to adhere without the skin pushing it off. But if patients have a good configuration of their eyelid and eyebrow, and if they're motivated and again have a temporary disruption of their facial nerve, then this can be a nice non-surgical option for loading that upper eyelid and allowing closure and allowing a better blink. For permanent eyelid weights, the things to recognize are that it gives passive, not active closure. So closure is entirely dependent on gravity, not on the patient being able to squeeze the eyelid closed. So it doesn't help with what we call nocturnal lag ophthalmos, which is where the eyelid props open at night, because especially if a patient is a back sleeper, if anything, the weight can work a little bit against us in that scenario. So sometimes patients still have to tape their eyelid closed if that's an issue. We select the weight in clinic by taping one similar to that MedDev weight. We have a series of weights in clinic that we tape to the eyelid and just get an immediate effect, and you can see how that helps with the closure. And that eyelid can go either in a pretarsal, meaning just above the eyelashes, or in a supratarsal, so up in the little dip in the upper eyelid. And we can choose gold versus platinum and solid versus chain. I typically use a solid gold weight, but there can be some advantages to the platinum weight. And this just shows a patient who came to see me with a previously placed gold weight in her left upper eyelid. And the weight had started to shift down. So it had been placed in the supratarsal location. And on the left-hand part of the screen, you can see how it looks when she's looking straight ahead. And in the bottom part of the left hand, you can see when she closes her lid, you can see that weight as a bump underneath the skin, but it gives her very good closure. We moved her weight to a supratarsal location. So we moved it up higher in the eyelid so that you no longer see it there by the eyelashes, and the configuration of her eyelid skin is such that it really hangs over. You don't see anything in that area above the eyelashes, and so her weight is tucked deep in the eyelid. And you can see with closure, it gives her good closure. It does not give as good of closure as the pretarsal weight. So with the supratarsal weight, we give up a little bit of closure, but for many patients, it gives better cosmesis, better appearance. And this just shows how that weight looks sewn into the eyelid. I won't go through too much of the technical aspects here in terms of the surgery, but this is the muscle that raises the eyelid, And that's a secondary muscle that raises the eyelid with the squiggly blood vessel going through it. And we place the weight in between those two muscles and then bring that main muscle down over top of it. You can see this patient has also had incision for a brow ptosis repair, a droopy eyebrow repair. So we can do those things in conjunction. And then we close the muscle over top of it. And you can see, so here was the patient before and after that gold weight placement. So whereas before we were seeing more of the white and the colored part of the eye, with that supratarsal weight placement, he's better closure. And then he has also healed up quite nicely at this stage from the brow surgery, which he had done on both sides. And then he also had a blepharoplasty, a skin removal, to try to lift some weight off of the eyelids. And here's his whole face photo just showing his reconstruction. This patient was well into his 80s, and so we did what we call static procedures. So we raised the brow, did that blepharoplasty, skin removal, put the weight in, and then did what we call a Labé procedure with one of our plastic surgeons. Samir Mardini did a Labé procedure to use the muscle up here and transfer it down into the lower face to help create a smile. All right, and then finally a few words on lower eyelid surgery. So the lower eyelid is very important and sometimes under-recognized in terms of its importance for eyelid closure. We think a lot about the upper lid and gold weights, but really the lower lid can be responsible for up to half of that inability to close the eyelid, what we call lag ophthalmos. And then it also plays a role in tearing symptoms that are a big issue for many patients. And then also it's certainly cosmetically important if the lower eyelid is asymmetric, and it can also be important for the fit of a contact lens in our contact lens wearers. And so there are different manifestations on the lower lid of facial nerve palsy. Retraction is what we call it when the eyelid just pulls down, but the eyelid margin stays against the eye. Ectropion is what we call it when the eyelid turns out from the eye, and then the other issues we won't talk about today. So let's just look at what happens. These are all patients who have facial nerve palsy, but at different ages. So in our facial reanimation clinic, we take care of patients really from birth all the way to well advanced in their 80s and 90s. And so these are all patients who had a congenital facial nerve palsy, and you can see that with that, there's some widening of the eyelid, but the lower eyelid is still well adherent to the eyeball. So it's in a lower position, but it's not tipped out. And then these patients in their 20s and 30s and early 40s have a more apparent lower eyelid retraction, so that widening of the eyelid fissure. And then as we get into patients into their 50s or so, that becomes more apparent, and then you can see that the eyelid just starts to tip away a little bit, especially in the woman on the left and the gentleman on the right. And then in our more elderly patients, really there's been a loss of some of the ligamentous attachments in the inner and outer aspects of the eyelid, and that allows the eyelid to then really fall completely away and have what we call an ectropion. So our options for the lower eyelids, and I'll just briefly go through these, are we can do what we call a lower eyelid retractor recession for mild cases. We can sometimes put in a spacer graft that can be, for example, some hard palate from the roof of the mouth. We can do what we call a tendon sling. That's really our go-to procedure for lower eyelid retraction, and canthopexy, and then less commonly mid-face suspension. So the lower lid retractor recession, this is that same patient we looked at before with the upper lid weight that had become malpositioned. The other thing that we noticed in her was that her lower eyelid on the left there sits down out of position compared to the right. And so it would be nice if we could just raise that up and get it up where it belongs, just at the lower border of the colored part of the eye. And so for this, we do a lower lid retractor recession, which is done entirely through the lower eyelid. And here are just the steps. So we make an incision on the back aspect of the lid, go in, kind of divide some of the tissue that includes the muscle that's pulling the eyelid down. And then we just let that sit down in a more lower position. Then we suture things closed with a dissolving stitch. And then that's what we see afterwards. So in addition to what we did on her upper lid, we were able to move her lower lid up by a couple of millimeters. The spacer graft, for example, a hard palate graft, that's something that we do when we really need support to build up the lower eyelid. I used to do this as a standalone procedure, but now I'm largely doing it with the palmaris longus sling, which again, I'll briefly talk about. And so we take a piece of hard palate from the roof of the mouth. This is a painful procedure for patients to recover from. And so for that reason, I'm glad that we have the palmaris longus sling. It's much easier for patients to heal from, but occasionally there's a role for this hard palate graft. And then we put it in the back surface of the eyelid, and you can see this patient on the left side is before with eyelid open and closed, and then after with the eyelid open and closed. So we were able to release his tarsorrhaphy, but despite that, still provide him with better closure by doing that hard palate graft plus that palmaris longus tendon sling. And so let me just talk briefly about the sling. So the sling we're using where we really need to get a good 3 or more millimeters of vertical lift, like this patient who has a lower lid and an upper lid that are really pulled apart because of the lack of the orbicularis muscle. And so we make a little incision at the inner part of the eyelid, and then at the outer part, we make an incision and drill a hole in the bone, take a piece of the tendon from the arm, shown here. We don't take the whole thing, and the arm function is not impaired by this. We take a part of the tendon that measures about 8 or 9 centimeters and put that into the lower eyelid, and that really functions as a hammock almost for the lower eyelid, and it lets us vertically elevate that lower lid. And so that this patient had that procedure in conjunction with several other procedures for facial animation, and ended up with really an excellent result both for her eyes, which were straightened. She also has 6 nerve palsy, and so my colleague Dr. Jonathan Holmes had straightened her eye, and then we also had better functioning eyelids for her, and she ended up with a great smile as well. And then finally, the lateral canthopexy is what we use in our patients where they have that completely paralyzed lid that tips out. That's actually the easiest of all these procedures to do for what seems to be the most severe manifestation. That's an incision on the outer part of the lid and tucking the eyelid up to the lateral rim. And so that this gentleman had that procedure again in conjunction with some other static procedures of the face. What are some of the limitations? So that lateral canthopexy is useful for ectropion, but it does not vertically elevate a retracted lower eyelid. The lateral tarsorrhaphy, the downside of that is it affects the peripheral vision and just doesn't look great. And then the hard palate graft or tendon sling are really our go-to procedures, especially the tendon sling for eyelid retraction. So just to summarize, if facial nerve paresis is mild and temporary, then often ocular lubrication or bandage contact lens is sufficient. If cranial nerve 5, corneal sensation is impaired, then really we need to aggressively protect the eye. We can put in that supratarsal placement of an eyelid weight that can give us better cosmesis with some compromise of function, but still often adequate closure. But I have plenty of patients who say, I'm all about function. I don't care if I see a little bump underneath the skin. I just want the maximum closure. And so that's a discussion that we have to make that decision together. And then finally, regarding the lower eyelid malposition can definitely play a significant role in ocular exposure, with age being the major determinant of the lower eyelid findings in facial nerve palsy. And a lateral canthopexy can be appropriate for ectropion, but for eyelid retraction, we're typically requiring the tendon sling or other more advanced procedures. All right, and with that, I will stop sharing my slides. And Melissa, I'm fine staying for an extra 5 minutes or so if we have a few questions.
Okay, we do. We have one that has been asked a couple different times, and that is that with facial palsy, how long after you start to experience that, and just using drops or ointments or patches or whatever, should you wait or can you wait until you have surgical intervention like a nerve graft or weight?
So yeah, so that's a great question. For the weight, that's not really a timing issue so much because that is a passive procedure. Mm-hmm. And a weight can be taken out. I mean, we hate to do surgery that then we reverse, but sometimes that it's a fairly low threshold to cross to put a weight in. But when we're talking, and again, I'm an oculoplastic surgeon. I'm not a facial plastic surgeon or plastic surgeon, so I'm not doing the reinnervation myself, but work closely with our colleagues who do that, and as part of our facial reanimation clinic. And so really the key thing there is that when the nerve is gone, then the muscles start to degenerate. And so we think that we have maybe not quite a year. We're more comfortable if we're intervening at, say, 8 months. And so we like to see these patients fairly early on, recognizing that a significant portion of them are going to recover, but we'd like to see them within a couple months from the surgery so we can get them all plugged into our clinic. We can follow them. If at 6 months they're really showing no sign, but the signs can be subtle at 6 months, but at 6 months it seems like they're not getting any recovery, then we'll start to think about either doing what we call a babysitter procedure, where we're taking, and this may be familiar to everybody, so spare me if it is, but so we take one of the other nerves, like cranial nerve 5, hook it up to those facial nerve muscles to keep them innervated. And that gives some movement with a jaw bite. And so this is babysitting in the fact that it's keeping those muscles alive. It's giving them some innervation. And then for some patients, that's actually enough. But if not, because if they're not getting the spontaneous smile, then that has bought us some time, so that then at 8 or 12 months, then they could have potentially cross-face nerve graft still to their own muscle, their own facial muscle. If for whatever reason we get beyond that, because not everybody can take that on, if it's a malignant process and they're undergoing chemo and radiation, that's just a lot to undertake in that first year. Or sometimes we see patients who have, Bell's palsy and they're not referred to us until 5 years after. Then that involves replacing the muscles with muscle from someplace else, either the gracilis muscle or the latissimus muscle, some other muscle, and then innervating it. So it does become more complex once the facial muscles have kind of died off or atrophied. But yeah, we're thinking in about 8 months, we really want to have a plan in place to act pretty quickly in between that 8 and 12-month period.
Okay. And so if you have patients who are 5-10 years out, who are continuing to have to use drops and patches and things like that, even with the weights and lifts and tucks and different surgical procedures, but they're still struggling with that. How do you advise those patients? Because it does tend to really affect quality of life.
Absolutely. So I would say we can get most patients pretty functional especially with the addition of sometimes that scleral lens can be just a tremendous help to patients. Now, understandably, in some of our older patients, there's a reluctance to pursue that, but our optometrist is great at working with our older patients even. Sometimes between arthritis or hand tremors or head tremors, it can be difficult for an older person to insert a contact lens, but we have just a great optometrist and technicians who are able to work. There's even like a little cup where patients can put the lens on the cup and get their eye down towards it. So we really do try to make that treatment available to anybody who's willing to work at it and give it a try. Between that, sometimes we have to resort to a tarsorrhaphy, but that is really pretty rare. Usually we can rehabilitate patients with the other things that we have in our toolbox.
Okay. And you mentioned that you typically use a gold weight. What are the advantages to gold versus platinum, or specifically this person asked about the advantages of the platinum weight?
Right. And so platinum is a little bit more dense than gold, and so it has a slightly lower profile than gold. And so in that pretarsal location, it can have a certain advantage. It's more expensive, and so if it's not covered by insurance, then that can be more out-of-pocket expense for the patient. And then the gold, it also comes in a chain similar to a watch chain.
Yep.
With that being touted as being more flexible, but really the solid ones conform very nicely to the tarsus. And I have had one patient where she was really bothered. She could feel every link of the chain and she kind of just couldn't resist playing with it. And so actually extruded the weight because of that. And so that, just that one experience that made me a little bit more reluctant to place the platinum link, because I just don't see a big advantage of the link.
Sure. Okay. We have two more quick ones. One is that the patient has minimal tear production on the AN side, and so is wondering if there's any at-home remedies or things that they can do to stimulate tear production.
I mean, that's a tough one. Restasis drops, which is a cyclosporin drop. That's the one, proven way to increase tear production. I would say in my patients, I haven't had it be a game changer. I'm not a dry eye specialist, but I definitely do work in conjunction with our cornea and dry eye specialists in those cases. The scleral lenses can be helpful, and we even have a couple of patients who are optometrist managers who have two scleral lenses. They actually wear one during the day, and then they sterilize that, and they put a brand new clean one in and actually sleep in their scleral lens. So again, just a couple patients with them, but if need be, that is an option.
Okay. And I don't know what this question means, so I don't know if you will either. The question is, can you discuss the use of plugs? Does that make sense to you?
Yeah. So punctal plugs. And so that's a little plug that goes in the tear drain.
Okay.
And keeps more moisture on the eye. That balance between being too wet and too dry is a big challenge in patients with facial nerve palsy, because that facial nerve is so important. It provides tear letdown, so patients can be dry because they don't have reflex tears. But then it also is part of the tear pump that propels the tears into the tear drain. And then if the lower lid is out of position, then the tears that are made often just sit there, and patients actually have tearing. And so they're telling us sometimes that they're tearing, and we're telling them that they're too dry. And so it can be a really frustrating mixture of the two. But so plugs can definitely help keep more tears that are made on the eye, but it relies on having the lower lid in a good position. The lower lid is pulled away from the eye. The tears aren't making it into the tear drain anyhow, and then the plugs don't really help.
Got you. Okay. Well, I know that you have a very short time frame. We really, really appreciate you staying with us and answering a couple questions, and for this great information. This has been fantastic. So I really appreciate you doing it. We have our last presentation for the day. Today will be at 5 p.m. Eastern. We will be joined by Dr. Daniel Price, who is going to talk about facial reanimation surgery. So we're excited for that. You can join us.
Yeah. Dr. Price and I work together all the time. So he will have.
And I thought that maybe if there's questions here that that didn't get answered, maybe that might be a place where we can talk a little bit about it too. So again, I really appreciate your time. Thank you so much.
All right. You're welcome. It was a pleasure. Thanks, Melissa.
Thank you. Have a great day.
Bye.